Well...
Oh, let me introduce you. For those of you that don't know, this is Kenneth Olivier. He's or Oliver, sorry.
In the Midwest we say Oliver.
Yeah. He's the program director of Mayo Clinic and the vice chair for ADROP.
Or chair of vice.
Chair of vice. But last year we were lucky enough to have Bob Dewalla was here, gave us kind of some concluding thoughts. So Ken came down from Mayo and invited him to give a little.
Right. The quickest slides as fast as he can, so people can go bowling. And I want to know, are the bumpers going to be down, Dan?
I don't know if the lanes are available left.
There you go.
They do have bumpers.
So I want to talk a little bit about kind of a high view of what I see going on in radiation oncology, more from the, what does that look like, at least from my position in ADROP. And I really, this quote kind of stuck with me when I thought about what we're facing. This is really specific to radiation oncology in the United States, by the way. And what we're currently going through. But anyway, I thought it was good to think about it. It was the best of times, it was the worst of times. And I think in the context of it's the best of times, we are making huge inroads in what we do in the patient's cancer care. Durvalumab plus radiation therapy is amazing. And it's really hard to make a case for patients with stage 3 cancer that they should be getting anything else. It's so impressive. And at the same time, we're developing new ways that we interact with patients in a curative way or in a prolonging overall survival way with patients with metastatic disease. And it's not just one trial, it's multiple trials looking at the same thing. And so from the perspective of me, what do I see in the field? The field is doing awesome. We have a lot of new things that we're doing, and those things are exciting. And they're making patients live longer with great quality of life. It's an exciting time, I think. Additionally, we're coming up with new ways to radiation for things that are not even oncologic. This work with Cliff Robinson could be a huge part of our field going forward and is really exciting and innovative. Additionally, we're taking our technology, photon radiation therapy, and marrying it with other very cool technologies like MR. And so we have MR Linacs now. We're getting better and better at proton therapy, particle therapy, which is taking physics to the next level for our patients. And we're even marrying these two technologies together to create MR-guided proton therapy. And all these things, in my opinion, say how great our field is at the moment. Additionally, I think many people are proving what a value radiation oncology is to cancer patients both here and around the world. This is in the Green Journal from people from Australia. They still be here, are doing an outstanding job showing to the Australian people what is the value of radiation oncology for cancer care patients, and it's excellent. At the same time, just a little Twitter tweet, but compared to what other things are, what other drugs and things are costing so much money to the American healthcare system, we're at about $2 billion compared to this. So if you think about that, the value of radiation oncology for cancer patients is really spectacular. Additionally, this idea of non-communicable diseases, that's a hot topic right now in global health. And I think radiation oncology is right at the forefront of this important concept. You already saw a little bit today about this idea of RIOS contra cancer. This is run by an intern, if you can believe that. He's not even started his residency in radiation oncology yet. They're very excited and passionate about this, and they're doing a lot of teaching. And we have, additionally, Radiated Hope, which is providing both education, brachytherapy equipment to the developing world. So from the perspective of how do things look, like if I was going to advise my children, I'd say, it's a great time to be a radiation oncologist. Is that a sign? I'm trying to it's a great time to be a radiation oncologist, and I would recommend anybody to go in the field, including my own children. But at the same time, that's not the whole story. I was thinking of that quote, the kids are not okay at the moment. So trainees are seeing things from a very different perspective than us. And a lot of times they have a wisdom that people in the field don't have. This slide, I don't know if you can make that one go off. Oh, there you go. This was just in Pro this week, talking about the match and the discrepancy in the number of unmatched slots this year in radiation oncology was 15%, which is a new record in a bad way. And the number of people actually going into the field has decreased a lot. And one thing that I'm passionate about and I've talked a lot about, at least on Twitter, I don't know if that counts as talking, but the number of women going to radiation oncology is declining. And most of the rest of medicine, the number of women is kind of growing, and we even heard talks about that today. So we're doing really poorly in terms of recruiting women to the field. And in my perspective, if we don't have women going into the field, it's a sign of real long-term weakness for the field. So that's something we really have to do better. This is well known. I got this courtesy of Aero, Chilean, connecting me with this data. They're upset, and this driving down our match is in part related to poor results on the ABR exam, which everybody knows well. And if you ask residents what makes them upset, what are they worried about in our field, they're worried about the job market. They think we're oversupplying radiation oncologists in the United States. They're very worried about the ABR physics and rad bio exam, and they're worried about resident expansion. This is data. We still have program directors in the audience, I'm sure. I don't know if any of you guys got onto the ACGME site and downloaded those case log reports. So this is case logs for all graduating seniors in the United States last year. And it's a very busy slide. A couple things I want to point out is these are the number of simulations for patients in different sites. And I included the average, but I also included the minimum. And what I want to point out to you is that in radiation oncologists trained in the United States, you can complete a residency program and be board eligible having done only 2 intact breast cancer patients, 4 prostate cancer patients, 0 Hodgkin lymphomas, but you will have done 12 pediatric cases. Why is that? Because the ACGME requires that we do 12 pediatric cases, and they don't set a minimum for these things. Now, we just had a great lecture speak about the importance of mastery and repeating things over and over to try to get better. It's really hard to make a case that we're doing a good job of that in the United States when we allow people to graduate with essentially not having done any of these sites, including, I didn't put the G group on here, a little bit I did. People are finishing having never done a pancreas cancer or esophageal cancer, and that's tragic in my opinion. So Aero did a survey of residents and said, so what do you think about what's going on with radiation oncology? What worries you about what's going on in Radon? And a couple of things stood out to me because, I'm in a leadership position in Astro and in a residency, and I think that they're right. I can't say that that's not true. We have not done a good job leading our groups and looking at this data, which has been, this is just the first time we've seen it, but it's been like this before, and really making an adjustment when we could have. So this is the Aero circle of woe or sadness, depending on your point of view. But I think that this is the center of what we have going on currently. When we have unhappy residents, they communicate that to medical students, which decreases our quality of applications, which decreases the quality of the trainees, which leads to unhappy radons, and around the circle we go. And just as a point, we need really good physicians and good trainees to produce cool things like an MR proton signal. And in order for us to have those things, we have to get the best residents in the field. We have to continue to train them and teach them how to do interesting research and take care of patients. So, I'm almost done. I don't know how I'm doing. I don't see a red light yet, which is good.
You don't get a red light.
First of all, so what are the marching orders for me? Like, what do I think are priorities that I should have, or what we should be doing as program directors and leaders in the field? I think first and foremost, we have to reassure the trainees that we care. It's ironic that in our field we have to be empathetic and remember the residents are experiencing something that was very tragic with the work failure rate, and we didn't take the time to say, you know what, that really did suck. And so I just want to reassure people that we do care about that. I'm on an ABR advisory committee, and we're going to try to take a crack at modernizing the ABR exam. I think that'll happen over the next several years, but we're going to try to improve the ABR exam, possibly sort of like what Andrew and Lee proposed recently in the Red Journal. I think we really have to rethink about what are the ACGME requirements so that we have minimums for all the common sites, the definitive common sites that patients are presenting in our cancer centers. There should be a minimum number of that, just like we have minimum for peds. I think we have to retake the narrative of our specialty. I'm on Twitter. Several people here are on Twitter. A lot of my favorite people are on Twitter. Please consider getting on Twitter and talking about what's good about the field, asking questions. I think actually Twitter is a great way to put a little pressure on the leadership in radiation oncology. They follow very closely. Whenever I sit down with ASTRO representatives, they're very aware of what's being said on Twitter about the field. So it's a good place to kind of make your comments about what you're worried about. And longer term, I think we need to consider creating a real curriculum for radiation oncology headed by somebody like Dan Gold. But other groups are doing this. I don't know how you say, like we were just saying earlier, the only thing ASTRO has over the RADONC program from Australia and New Zealand is that it's easier to say our acronym. How do you say that?
RANSA.
Oh, there you go. We still have that. We have one thing that's better. But this group is really doing amazing work. They have a full curriculum for radiation oncology. It's outstanding. The way they examine their trainees, I think, is far advanced from what we do. So if you ever want to check it out, it's really neat. You know, we should be doing this. We're not leading. We're actually really far behind, I think, educationally. Also, I'm excited about the future of the field in some respects. You know, we've been led by people that look like me for quite a while. And this next year, we will definitely have a woman president of ASTRO, and that's exciting. So there's opportunities to make changes. Of the 4 positions that are being elected in this next year, only one of them will be a man on that group. So that, I think, is a positive thing. So we need excellent people like you from Arrow. Don't forget to tweet and take part in social media. ROECSG is an outstanding way for us to participate in education. And thank you. That was it.